Good morning, everybody. I get to, with each course, get to lead the session on gastroenterology, and we're going to start with a very quick discussion of causes of abdominal pain in children. I would like to tell you that the objectives are to review the characteristics of chronic abdominal pain, to distinguish functional from organic causes of abdominal pain, and using a series of cases, we'll talk about the evaluation and management of several different causes of abdominal pain, which are listed here, and include peptic ulcer disease, acute intermittent porphyria, choledochal cyst, cholelithiasis, functional abdominal pain, pancreatitis, and UPJ obstruction. Some of these you may see on the board, so it's important to just review these as well. So let's just start, and I would start by telling you that some of the cases that you see may be very long, so you need to be careful to read the whole case. Sometimes it's a little bit challenging as you get to the end of the testing to read them all. But let's start with case one, which is that of a 13-year-old girl who's brought to your office for evaluation of abdominal pain that's been present over the past 4 months. Her pain is poorly localized to the periumbilical area without localization or radiation, and she rates her pain as a 6 out of 10. Her pain is worse in the morning and also may be present in the afternoon and before bed. There are no specific triggers such as diet or activity that precipitate her pain, and she does not have a history of change in her appetite, nausea, vomiting, change in her stool pattern, or weight loss. She's an otherwise healthy girl. Her parents are most concerned because she's missed 1 to 2 days of school per week for the past 3 months, and on exam, she has no noted abnormalities. So how to proceed, and in terms of the evaluation of chronic abdominal pain, there's some discussion about how much testing, if any, to be done in children, particularly those patients who do not have any concerning symptoms. But by and large, these are a list of tests that we typically do. A CBC, a comprehensive metabolic profile, sed rate, celiac screenings, stool for blood, a urinalysis, checking the stools for parasites, and more recently, some people might advocate doing a fecal calprotectin, which is a nonspecific test for intestinal inflammation, a lactose breath test, and a fructose breath test, all of which in this circumstance were normal. So what is the most likely diagnosis as the cause for her chronic abdominal pain? So this is your first question. A, Crohn's disease, B, celiac disease, C, pancreatitis, D, functional abdominal pain, or familial Mediterranean fever. See, we all can go home and go back to sleep. So the most likely diagnosis of functional abdominal pain, we can talk about that a little bit, but it's the most common complaint, one of the most common complaints in children, and certainly represents a large number of the patients that we see in our clinic. It's seen in 13% of middle school children, 17% in high school children. And the important thing is to distinguish those children who have a functional disorder versus those who have an organic cause for their pain. And it turns out that the majority of the children that we see have functional abdominal pain. The red flags that one should consider in evaluating a patient with chronic abdominal pain, which would suggest an organic cause, are listed here, and they include persistent right upper quadrant or right lower quadrant abdominal pain. So that pain really on the left side usually is functional, and pain on the right side, if it's localized to those areas, one should be more concerned about a functional or an organic cause. Symptoms of dysphagia, persistent vomiting, GI blood loss, severe diarrhea, arthritis, unexplained fevers, delayed puberty, or involuntary weight loss. And on physical examination, red flags would include hepatosplenomegaly, the presence of an abdominal mass. We need to focus on the importance of looking at the perianal area, looking for perianal disease specifically as an indicator of inflammatory bowel disease. And those children who have a family history of celiac disease, inflammatory bowel disease, or peptic ulcer disease may warrant more specific testing. So functional abdominal pain is uncommon in children who are younger. It's more common in young girls compared to boys. And it's important to recognize that the pain that these children experience is real. So it's not simply an excuse not to go to school or get out of doing something that they don't want to do. There's the biopsychosocial conceptual model of functional abdominal pain, so that it really represents an interrelationship between psychosocial factors and physiologic factors. And we often explain the brain-gut axis to families who have children with functional abdominal pain, meaning it's real, it's something that they feel, but it's not rooted in inflammation. We do know with regard to functional abdominal pain that there may be some genetic and environmental factors, since we know that there is some clustering of functional abdominal pain within families. And these symptoms represent abnormal bowel reactivity to physiologic stimuli, whether it be meals, abdominal distension, hormone changes, an infection, noxious stimuli, or psychological stress, leading to the development of visceral hypersensitivity or hyperalgesia. Functional abdominal pain is a positive diagnosis. It is not a failure to identify the true cause of abdominal pain, so that families sometimes feel that we don't believe that their child has pain and we can't figure out what it is, but it really is a real diagnosis, something that you can discuss with families and explain to them that it does exist, but it's not something to be concerned about, but certainly something that needs to be effectively dealt with. So there are classifications of functional abdominal pain disorders, which are called the Rome 4 criteria, which more recently were revised in 2016. They're divided into many different groups, but under the umbrella of functional abdominal pain, there's functional dyspepsia, which is postprandial upper abdominal pain or epigastric distress. The second type is irritable bowel syndrome, be it IBS-C, IBS-D, or IBS mixed, which is pain related to defecation, a change in bowel frequency, stool frequency, and either in the form of diarrhea or constipation. And then the third category is functional abdominal pain not otherwise specified, which is episodic or continuous abdominal pain that does not occur solely during physiologic events such as eating or having a bowel movement. And it's important to recognize that there can be overlap between different forms of functional abdominal pain, so that you can have functional dyspepsia and IBS at the same time. And the fact that you have functional abdominal pain does not exclude the presence of another organic disease. So that, as an example, we see many patients with inflammatory bowel disease that may have an IBS overlay, so that you can have both. So the next question is, the most appropriate initial treatment for a child with functional abdominal pain is A, education, reassurance, limiting pain-induced disability, cognitive behavioral therapy, self-hypnosis, tricyclic antidepressants, or acid suppression, antispasmodics, and laxatives. So the correct answer is A, although admittedly all of these are potential treatments for functional abdominal pain. So first we start with education, reassurance, explaining the brain-gut axis, and limiting pain-induced disability. But similarly, we use cognitive behavioral therapy, sometimes use acid suppression, antispasmodics, and laxatives, and occasionally use antidepressants, which can be helpful in this particular population. So on to case 2. Case 2 is a real case of a 13-year-old boy who is brought to your office for evaluation of epigastric abdominal pain that has been present for the past 2 months. His mother, an adult gastroenterologist, has treated him with a PPI with partial improvement in his symptoms. He has associated nausea and he's lost 2.5 kilograms over the previous 2 months. His examination was remarkable for moderate epigastric discomfort, and his labs are as noted below, which suggests that his hemoglobin is slightly low, but otherwise everything else is normal. So the causes of epigastric abdominal pain in children include functional dyspepsia, the spectrum of GERD and esophagitis, gastritis, peptic ulcer disease, and pancreatitis. So with this question, what test would be most helpful in this particular case in establishing this diagnosis? A, an abdominal ultrasound, B, a CT scan, C, an upper endoscopy with biopsies, D, H. pylori antibody titer, or E, amylase and lipase. So the answer to the question is an upper endoscopy with biopsy, so that it's certainly reasonable in a child with epigastric abdominal pain to give them a trial of a proton pump inhibitor. But if they don't improve, it's appropriate to do an upper endoscopy to determine how much inflammation they have, if they have H. pylori, if they have esophagitis, if they have eosinophilic esophagitis, so that C is the answer. With regard to serum H. pylori antibody titers, the serum test is not a particularly reliable test in children, and as I'll discuss in a minute, a much more reliable test would be an H. pylori stool antigen test. So here are images of a particular patient who does have an ulcer, and here is a large duodenal ulcer. Here is evidence of nodular antral gastritis. You can see the pylorus, which is here to the right, and the nodular mucosa, which is here to the left. And as you see here, biopsies are from the patient who has H. pylori, and it's a little bit hard to see, but H. pylori colonizes the surface of the intestine with these gram-negative bacilli, which are on the surface, which are seen with a Giemsa stain, and that's how one makes that diagnosis. So what do you need to know about peptic ulcer disease? Duodenal ulcers are more common than gastric ulcers. Boys more commonly have ulcers than girls. Primary ulcers are localized more often to the duodenum, whereas secondary ulcers, those related to things like stress and non-steroidal anti-inflammatory agents, are more commonly gastric. In children, the symptoms associated with peptic ulcer disease are variable, not always typical of what you would think of in an adult with an ulcer, but typically epigastric pain, some relationship to meals, sometimes nighttime pain, and almost half of them have a component of vomiting. The causes of peptic ulcer disease are listed here, and they include H. pylori, non-steroidal anti-inflammatory drugs, aspirin, alcohol, seen in the circumstance of stress with shock, trauma, and sepsis, with excessive production of acid, in more unusual circumstances, such as patients with Zollinger-Ellison syndrome, systemic mastocytosis, and renal failure, and in other conditions that we sometimes see, which are listed here, which include eosinophilic gastroenteritis, Meniere's disease, autoimmune gastritis, and in patients with inflammatory bowel disease. But again, the majority of these cases are related to the presence of H. pylori, which is an S-shaped gram-negative bacillus. It was first described in 1983, and prior to that, we thought that ulcers were predominantly related to stress, but now we know it's related to a bacterial infection. As I previously mentioned, H. pylori colonizes the surface of the gastric mucosa and can be associated with a variety of symptoms, meaning the development of acute chronic nodular antral gastritis, which is most common, the presence of gastric ulcers or duodenal ulcers. There are many people who may have this infection and can be asymptomatic, and H. pylori is in the differential diagnosis of unexplained iron deficiency anemia. The gold standard in making this diagnosis is an endoscopy with a mucosal biopsy. At the same time, you could get a piece of tissue and do a rapid urease test, which is a CLO test, which is a little bit of an antiquated test, but we have used that in the past to make this diagnosis. There's an H. pylori breath test, which is rarely used to make the diagnosis, but is often used to confirm eradication. And the H. pylori stool antigen test is very sensitive in identifying this infection. The treatment is triple therapy, which includes a proton pump inhibitor and a combination of 2 antibiotics. The first-line therapy is primarily using amoxicillin and clarithromycin. Case 3 is that of a previously healthy 3-year-old girl who's seen in your office for evaluation of recent onset of right upper quadrant pain and scleral icterus. Her examination was remarkable for moderate jaundice in the presence of right upper quadrant mass. Her laboratory studies were as listed below. So what is the most likely diagnosis? And here is a copy, an image of her ultrasound. An intestinal duplication cyst, pyloric stenosis, hydronephrosis, colodocal cyst, or E, constipation. So the answer is that this is an image right here, of a choledochal cyst. And as with some of the board questions, you may not know what this ultrasound is or be able to look at an ultrasound, but you can certainly look at the history and get the idea of what this might be. So what are the important facts about choledochal cysts? They are congenital cystic dilatation of either or both of the intra or extrahepatic biliary tree. There are 5 different types. The most common type is type 1, which is dilatation of the common bile duct. It is more common than girls than in boys, and more common in patients who are of Asian descent. And it's a fairly common cause of neonatal, or it's not a common cause, but it is a cause of neonatal jaundice, in that 50% of patients with choledochal cysts present in infancy with neonatal jaundice. The remainder of children present with typically a clinical triad of jaundice, moderate abdominal pain, and the presence of an abdominal mass. The complications of a choledochal cyst, other than the obvious obstruction, is cholangitis and pancreatitis. It's diagnosed by ultrasound and often confirmed by MRCP, and it's treated with complete resection of this area. And if you were taking your pediatric GI boards, you would need to know that that area needs to be monitored for the development of cholangiocarcinoma as children get older. So case 4 is a 16-year-old boy who's seen in the emergency room with acute onset of severe epigastric and left upper quadrant abdominal pain radiating to his back, associated with nausea and vomiting. He has otherwise been well, with the exception of having a mild URI in the week prior to his visit, and the day before he was seen, he fell off his bike while dirt biking. He's not on any medicines. He has no family history of GERD, peptic ulcer disease, pancreatitis, or gallstones. And on physical examination, his vital signs are stable. He has evidence of moderate dehydration. He's more comfortable in the knee-chest position or leaning forward, and he has moderate left upper quadrant and epigastric discomfort. So what laboratory tests would be the most helpful in confirming the diagnosis? And the options are A, his AST, B, an ALT, C, an amylase and lipase, D, a serum glucose, or E, a urinalysis. So the answer to this question is C, and that this is a very classic example of pancreatitis in a young child. I think that we have increasingly recognized the frequency of pancreatitis in children, and it's a frequent reason for admission. It's important to keep in mind that in checking for pancreatitis, we often check amylase, but a more specific enzyme is lipase for pancreatitis, and that amylase can be elevated in numerous other conditions, which are listed here. Macroamylasemia, salivary gland tumors, infections such as mumps and intestinal obstruction. It can be elevated in diabetic ketoacidosis. Amylase can be elevated in the circumstance of ovarian torsion and renal insufficiency in patients on opiates. And amylase and lipase, in order to make the diagnosis of pancreatitis, need to be 3 times the upper limit of normal. On the other hand, lipase may rise sooner, it is higher, and it may last longer. So if you had one test to do, lipase would be the more appropriate test for pancreatitis. So the clinical presentation things to remember are the symptoms can be relatively nonspecific. The pain can be of sudden onset, radiates from the upper abdomen around into the back, and is associated with nausea or vomiting. Physical findings are typically left upper quadrant or epigastric pain. In more severe cases, you may see mild jaundice, shock, hypotension, ecchymosis of the flank, which is from your medical school days, Turner sign, and blue discoloration of the umbilicus colon sign, which are more typically seen in fulminant pancreatitis, more often seen in adults. Again, laboratory findings are amylase and lipase greater than 3 times the upper limit of normal. The diagnosis is confirmed with a pancreatic ultrasound, not only to examine the pancreas in terms of finding decreased echogenicity and hypertrophy, making sure there's no dilatation of the pancreatic duct or presence of pancreatic fluid, but as importantly to evaluate whether or not there's the presence of gallstones or evidence of biliary obstruction. The causes of pancreatitis, the most common ones are seen on the left-hand side. which are biliary disorders such as gallstones or colorectal cysts, again mentioning trauma, pancreatic disorders such as cystic fibrosis, diabetes, and an anatomic variant, pancreatic divisum. Many of the cases that we see are idiopathic and we never identify a cause. Medications can cause acute pancreatitis in many categories, but most notably with regard to antibiotics and anticonvulsants, and also can be caused by infections. On the right-hand side, there are some metabolic disorders that are associated with acute pancreatitis, which include hypercalcemia and hyperlipidemia. Again, there are other less common causes such as vasculitis, the presence of a duodenal ulcer that's eroding into the pancreas, the contributing factors such as toxins, including yellow scorpion bites, which I've never seen, and other multi-system disorders which may have pancreatitis as an inflammatory component. In addition to acute pancreatitis, we also see circumstances where we have patients who have recurrent bouts of pancreatitis and develop chronic pancreatic inflammation that can be a cause of chronic pain. So that chronic pancreatitis is a progressive pancreatic inflammatory disorder with recurrent or persistent abdominal pain with ultimately the potential for the development of pancreatic insufficiency and endocrine insufficiency. The causes of chronic pancreatitis are similar to those that we discussed on the previous slide, but again include the category of idiopathic, some structural abnormalities, the presence of strictures within the pancreatic duct, also hyperlipidemias type 1, 2, and 5, hypercalcemia, cystic fibrosis, and inflammatory bowel disease are also associated with chronic pancreatitis. We often look for hereditary disorders which are associated with pancreatitis, which are listed on the right-hand side, which are typically done by geneticists, but are checking for PRSS1 gene mutations, which encodes for cationic trypsinogen, SPANK1 gene mutation, which is a mutation in the pancreatic trypsin inhibitor, and CFTR mutations. There's also a form of autoimmune pancreatitis, and idiopathic fibrosing pancreatitis, which are in this category as well. So case 5 is a 9-year-old boy seen with history of chronic intermittent severe left-sided abdominal pain for the past 3 months. His pain is localized to the left upper quadrant with radiation into his left flank. He was seen in the emergency room for evaluation of his abdominal pain, vomiting, and dehydration. He has not had a history of fever, dysuria, or polyuria, and his exam was remarkable for left upper quadrant fullness. So as you can see, he too had an ultrasound, and the most likely diagnosis is A, cyclic vomiting, B, appendiceal colic, C, intestinal malrotation, D, UPJ obstruction, or E, diabetic ketoacidosis. So we all are not ultrasonographers, but this is an example of a hydronephrotic kidney, and the answer is that this particular child has UPJ obstruction. UPJ obstruction is one of the most common causes of lateralizing pain, and obviously this pain radiates into the flank, which is most consistent with this diagnosis. UPJ obstruction is the most common cause of urinary obstruction, a urinary obstructive lesion in children. It represents a congenital narrowing and most often partial obstruction of the UPJ region. You can have intermittent symptoms so that you may occasionally miss this at initial diagnosis if the patient is asymptomatic, and it's best to make this diagnosis when the patient is having pain. The incidence is 1 in 500 live births. Boys are affected more than girls, and it's more frequently found on the left side. The symptoms associated with UPJ obstruction are colicky abdominal pain, lateralizing to the back or flank, associated with nausea and vomiting, sometimes not, a palpable renal mass, and a hematuria. It's diagnosed by ultrasound, and again, the findings may be present only with an acute episode of pain, and the treatment is surgical. So now we're moving on to case 6. And this is a longer case, but it's a 15-year-old girl with sickle cell disease who's seen in your office with a 6-month history of intermittent right upper quadrant pain and nausea. She has been admitted several times over the past 6 months with pain crisis. However, this pain is distinctly different. Her pain is worse after meals and occur at any time of the day. Her past medical history is otherwise unremarkable. Her exam is normal, although she confirms that when her pain is present, she localizes her pain to the right upper quadrant, and it's quite severe. So what is the most appropriate imaging modality to order? A, a CT scan, B, a hepatobiliary scan, C, an abdominal ultrasound, D, an MRCP, or E, a KUB. So the answer is C, and so this is a case that's most consistent with the diagnosis of gallstones, and here's an ultrasound of a patient with gallstones, and you can see within the gallbladder these stones which are present here. You can see the typical acoustic shadowing which people describe when they describe biliary stones, which helps to distinguish stones from something like sludge. Or a polyp, and so that is the typical appearance of gallstones. So what type of stones would you find in a patient with sickle cell disease? Would you see cholesterol stones, pigmented stones, calcium oxalate stones, or uric acid stones? So the answer is B, pigmented stones, because these stones in this patient are related to hemolysis related to sickle cell disease. And so what are the important facts about gallstones? The symptoms can be relatively nonspecific, but typically they are pain that's colicky localized to the right upper quadrant associated with nausea and vomiting, sometimes with jaundice and fatty food intolerance. These stones develop as a result of precipitation of the insoluble constituents of bile, which include cholesterol, bile pigments, and calcium salts. Calcium stones can be either pigmented or mixed, and the distribution in ages is that 10% of stones in children are in infants, which typically resolve spontaneously and don't require surgery, less commonly in younger children, and most commonly in adolescents, and those individuals most often have cholesterol stones. The predisposing factors associated with gallstones are hemolytic disease, such as sickle cell disease or hereditary spherocytosis, obesity, hyperlipidemia, infection, pregnancy, cystic fibrosis, those patients on total parenteral nutrition, those who have had an ileal resection or have distal ileal disease. Again, medications have been implicated as a cause of gallstones, which are listed here. It's diagnosed by ultrasound, and the complications include cholecystitis and pancreatitis. So the cholecystitis results in inflammation of the gallbladder, typically secondary to gallstone obstruction of the cystic duct. It can be acute or chronic. The symptoms are right upper quadrant pain, radiating sometimes to the back, associated with nausea. You may have a positive Murphy sign. The differential diagnosis of right upper quadrant pain is hepatitis, hepatic abscess, pancreatitis, Fitzhugh-Curtis, which is gonococcal perihepatitis, ulcers, pneumonia, pyelonephritis, and kidney disease. These are the tests that you would use to evaluate a patient, and again, it's diagnosed by ultrasound with findings of gallbladder dilatation and thickening of the gallbladder wall. So the last case in my minute and 23 seconds is that of a 15-year-old girl who's seen in the emergency room with severe abdominal pain that has become progressively worse over the previous 3 days. Her pain is poorly localized over her entire abdomen. She has associated nausea, and in the past 24 hours has become more lethargic and confused and has experienced diffuse muscle weakness. In the past, she's had similar episodes, although less severe. She has had an evaluation by a pediatric gastroenterologist and had $1 million workup, all done at a time when she was asymptomatic. As a resident in the emergency department, you obtain a careful family history which includes a history of Crohn's disease, ulcerative colitis, gallstones, and a history of acute intermittent porphyria in a maternal grandmother. So which test would be the most helpful in establishing this diagnosis? A urinalysis, B, urine amino acid screen, C, urine catecholamines, D, a urine HCG, or E, urine porphyrobilinogen. So it's great that you all recognize acute intermittent porphyria, something that you probably will never see, or at least I've never seen. Things to remember are that it is an autosomal dominant disorder with variable penetrance. It represents a deficiency in the enzyme porphyrobilinogen deaminase. Many people who have this disorder may never develop symptoms, and the symptoms may be variable and nonspecific, but classically the symptoms occur as acute attacks. Acute intermittent porphyria is more common in women than in men, and the pain that they have is not inflammatory, but it's neuropathic. The symptoms are severe abdominal pain in those patients that are affected. They may have nausea, vomiting, but also have a neurologic component with muscle weakness, confusion, hallucinations, and seizures. Symptoms may be precipitated by low carbohydrate intake, several medicines, or hormonal changes. And the diagnosis is made by urine porphyrin screen of porphyrobilinogen and alpha amino or delta aminolevulinic acid during an acute attack. You can test these enzymes in red blood cells, and there's a DNA test to confirm this mutation. So here are the answers, and I wish you all the best of luck.